Pediatric Lounge, a podcast taking you behind the door of the physician's lounge to get a deeper insight into just what docs are talking about today. From the clinically profound to the wonderfully routine and everything in between. This episode is sponsored by our friends over at Hippo Education. Quick question. When was the last time you felt you were fully up to speed on the non-stop updates in pediatrics? Let me guess. Never. That's where Hippo Education's Pediatrics Reviews and Perspectives podcast comes in. Your monthly pediatric cheat code. Fresh, up-to-date insights from pediatric clinicians who live and breathe the same challenges you do. No fluff, no boring lectures, just practical knowledge you can apply on your next shift. The best part, you can listen and earn CME whenever it works for you on your commute between patients or during that rare quiet moment. So, if you're ready to make staying informed easier, check the link in the description or visit hippoeducation.com to try Hippo Education today. Morning, George. Good to see you again on a Tuesday morning.
Yes, we are back, and today we have a repeat guest, Dr. Sean. And the topic of discussion is going to be a pediatrician's view on value-based contracts and the potential impact on child health and children.
All right, so you just triggered me again, but Dr. Jones is kind and courageous enough to join us for part 2. She's the president of Complete Child's Health, a practice that represents the future of pediatrics in the U.S. market. They're based in 3 pillars: acute care, preventive care, and chronic disease management, and being able to do that every day seamlessly for all their patients. They provide care for nearly 20,000 children with over 64,000 visits each year. Sean and I have a ladies' disagreement on the term value versus the term impact, as value payment systems to me seem like a ruse meant to deny care to children. But that's not how she defines it, and that's a topic of the conversation today. Welcome back, Sean.
Thanks. I'm happy to be here.
What is it that you mean by value and I mean by impact when we're talking about the work that pediatricians do across the country?
I think that value has impact. I don't think that it's one or the other, but I think it really is important how you define value. If value is just saving money, then that's not going to help patients and it's not going to help support practices like ours or large practices that are hospital-based practices. So really, value has to mean we understand what are the most valuable services and interventions that we can do for children, and that we reward those by paying for those and paying for those services. So when I think about value-based care, I think about care that actually has an impact on future health and actually makes a difference in the lives of children. And we're not wasting our funds on things that are unnecessary tests, unnecessary screenings, unnecessary interventions or treatments. And so that to me is what I think of as value-based care. I think the hardest part in pediatrics is defining how you put the dollar figure on the value, because the value is far into the future, not short term. And that's where we get into trouble when we're dealing with the business and money side of things. Is businesses deal on a 1-year cycle. They don't deal on a 10, 20, 50-year cycle. But in medicine, that's, especially in pediatrics, that's what we're dealing with, is a lifetime cycle.
So we'll get a little deeper into that, but
Yeah.
I'll tell you what I think of from a business perspective, what value is. I fly somewhat frequently. And so there's 3 things that I judge about. One is safety. I don't want to end up in the Potomac. That's not negotiable. That's one part of the value. But really, whether I fly Southwest, American, United, Delta, that is a given. They should land me in the airport they promised to land me after I pay for the ticket.
Uh-huh.
Then there's experience. And I'm not wealthy, so I'm not going to be paying for first class seats to fly from here to Nebraska. There's no value. I'm in the same bus. I'm going to get there at the same time as everybody else on the plane. What is it that I am paying for? But for someone else who's much wealthier than me, the comfort of being in first class or the show office of it so they can post a picture on Instagram has value.
Mhm.
And then, of course, there is, so, that is something that it's hard to quantify.
It's subjective.
And then there's a service component, right? I've got some airlines I like better than other airlines. They seem to treat you better, or I'm a frequent flyer with them and I get bonus points and I get perks. So that to me is how I think of that. That's very difficult in medicine, particularly in preventive medicine, the young adult and the children,
Mhm.
because it's a given. We don't want our doctor to give us something that kills us. That's fly the plane
That's a
and
no-brainer.
that's a
But
no-brainer.
but
But
unfortunately, not everybody practices that way.
no, but that should be a given. That should
Yeah.
not be something up for discussion.
Mhm.
But the customer might want extra service, like being in first class, like I want to be seen at 7 p.m. because it's convenient for me, but I'm not willing to pay a dime more for that. I'm going to pay the same as if I was seen at 10 a.m. And I want this clinician, not that clinician, but I'm not willing to pay a dime for that. And that's where the disconnect is. So that's big picture.
Sure. But
Uh,
it's not
smaller,
I
smaller
think
picture to us is that it's a ruse from the insurance companies, where it says you should provide value-based medicines for value-based payments. What are you valuing is what you alluded to a second ago, right? How much money did we save the system so that we can get the bonuses for the C-suites and the insurance plans?
and I think that
That's
depends
not
on how the
value.
contract is written, you know? So, if you're in a shared savings model ACO and you're not in a all ages ACO, right? Like we are, you're just in a pediatric ACO, you're that might be valuable to the insurance company, but there's no savings to be made. It's so small that it's not a feasible way of paying pediatrician. On the other hand, if you are into adult end of life care, you might be able to save a ton of money. And it doesn't make sense necessarily to do shared savings for that either, because it's too balanced on the other side. But if the value-based payments are predominantly based on we see the quality of your care as having a long-term value, then that is how we should be doing it. And I think the big problem is that we're not actuaries, right? We don't have that level of expertise. We would have to hire that out. Insurance companies are in the business of hiring actuaries and looking at risk. And they are not interested in looking out at risk 10, 20, 50 years because they're looking at their 1 year time frame. And we should be doing more to look at the financial impact of the care that we're giving now and how much money it's going to save into the future. And then based on that, figure out how we pay people. That's what I think. If you're going to do it on a monetary standpoint, you have to look at total savings. So if I get 75% of my adolescent patients vaccinated for HPV, how much money does that save on the system for all the patients who weren't going to get cervical cancer and anorectal cancer and or pharyngeal cancer, but mostly cervical cancer, right? So what is that impact? So I think that's where, if you're really going to look at shared savings as the model, that's where it should be going. I think that's impossible.
Okay. So you're gonna have to go humor me and listen to
Okay.
the Dr. McQueen's episode on these ideas because it blew my mind away. And he was flying at 30,000 feet, and I could
Uh,
only reach 2,000 feet with what he was talking about. It was just another, it was another level. We agree. What I'm
yeah,
saying is
totally.
the work that a pediatrician does, if they're doing the work properly,
Mhm.
has a tremendous impact in their community. And every little thing that we do, if we're doing it right, has a huge impact. It is extremely difficult to measure that impact because some impact doesn't have a dollar attached to it.
Correct. Yeah, that's what I
And so that's
employability and
and then and then you're absolutely right. It's foolish to talk about shared savings when we're not spending enough to prevent disease.
Yeah.
And so we're just shooting ourselves in the foot.
You're
We can have a
defining,
short-term save, but a long-term huge spend.
yeah. And you're saving because you're changing from the acute care, sick care model to a preventative care model. But the preventative care model is really where we should be, right? So why are we measuring savings going away from what we shouldn't be doing? Why don't we just pay people and reward people for doing what they should be doing? And that's what I see as value based care.
I think what they do is just like with anything in medicine, they take the adult model of
Yes,
something and try to
100%.
filter it down and squeeze the pediatric world into that model. And it never works. Just like the adult ERs back in the day, they should see children. We've already proven that you should have pediatricians in the ER. Same
Yeah.
thing with the hospital. And the reason
Yeah,
that you're
100%.
see the quality part of it, the QIP programs, they really do your checkups and you pass this metric, you will get X amount per member per month as a bonus to the practice. There's nothing wrong
It's
with
not a
that.
bonus. They're withholding payment from you. And then
Okay,
if they want to, they'll give it to you, but they can take it away anytime.
correct.
Yeah,
So
that is the biggest problem too. They can take it away anytime, right? So what happens with practices is they go into a model and they're sucked in because it's okay, this is extra money on top of what we're going to pay you. But then when the contract is up, they cut their fee for service payments and they say, oh, we're going to give it back to you on the value based side. Okay. And then with the next contract, they cut the value based offer. And because of the monopoly that the insurance companies have on the market, this is not a workable system. That's really the problem. The problem is not paying for value. The problem is that the system is not set up to allow value to push the market for what it actually is worth, right? Because we have these artificial rules. We have monopolies with huge areas of the country that have predominantly one insurer that has monopoly over the system. We have laws in place that say you must provide care in emergency rooms and those kinds of things. We have laws in place that say you have to provide the same level of care to all patients, no matter what their insurance is. So we can't do that piece that you were talking about, Herb, with the I'm not going to pay for a first class ticket and I'm not going to pay more
Right.
for X, Y, or
Right.
Z. So we have all these artificial rules that suppress the market from really allowing us to value what it's actually worth. So I don't think the problem was with the idea of paying for value. And it doesn't just have to be per member per month dollars, right? It could be we can see that your practice is doing more with patients and we value that more. So your fee for service payments are going to be higher. Those are the kinds of things that we could be doing. Because if my practice is doing depression and suicide screening on every single adolescent 12 and up when they come into the office, and down the street, they said, you know what, that's going to take too much time and that might make us run behind and we might have to see less patients, even though there's a standard. My service is of a higher value than their service. But that's not how we're looking at value. And that's how we should be looking at value.
And
that's
so
very well said. But also what happens in pediatrics, because they're using the adult model to go
Yep.
to the pediatric model, they put the quality, and most pediatricians, I don't know if all, but most do the right thing. They do have good quality, right? But they tie it to shared savings. Now, if you do the shared savings, then they'll pull in the quality money. Then they'll give you then you did really good. And then we'll give you a per member per month. And then congratulations, you made shared savings. In our clinically integrating network, we did have shared savings of a good couple of $100,000. You know when that was? During COVID. Our business went down dramatically. Quality was always there. So all of a sudden, it was a great thing. Open up the ERs. They're still going to the ERs.
But it was only pediatric, right? You're clinically
Yes.
integrated. Yeah.
So
multiple problems there, George.
Yeah.
First of all, not everybody has a per member per month contract.
right.
And that's very regional.
Yes.
And by product. Some Medicaid products have it, some don't. Some insurance companies have it, some don't. So that not everybody has it. Number two, if you listen to Sandy Chung's episode, She talked about how they got in trouble with shared savings at the CIN and the supergroup because during COVID, they were doing more physicals, and physicals are more expensive because
Right.
vaccines are expensive. And
Yeah.
so the insurance companies wanted to dock them
Yeah.
for spending more year to year.
Mhm.
And you got to be kidding me.
Yeah.
We're supposed to be doing more well child exams. You want me to stop doing well child exams to keep the spend below what you thought it was necessary? And they're
Again,
like,
back adult medicine to the pediatric model. It
there's
don't work.
nothing to do with
But,
adult medicine.
but I would argue that that is a problem with the way they have the value of, or the expected
Yeah.
spend per patient, because instead of, they were looking at it as last year's spend, this year's spend. If you look at the NACO's recommendations, they would say you really should be looking at the population. You should be looking at their risk. You should be looking at what the spend actually should be if you're doing everything correct, and then look to see if they're meeting the quality measures, meaning they're doing the preventative stuff that they're supposed to be doing, and they hit below, then you get your shared savings. But I think shared savings is a mistake. It's not a long-term measurement for adults, and it's not a measurement that works for kids. It has to be something
So
else.
for adults, I do think that you can have opportunities for higher quality at less expensive, like the same
Sure.
analogy. People will fly on the plane, but they don't need to be in first class.
Uh-huh.
If you're age, I'm not supposed to say old. If you're aged, dual enrollee, and you are bedridden, and we can provide care for you by sending a nurse aides to your house 16 hours a day. That's compassionate. That has just probably a better outcome than being in a nursing home, and is a lot less expensive.
Yeah, but they don't cover that.
Yeah, they
But
will.
it
Sometimes they do.
depends on your plan.
It
I'm
depends on
there
your
with my
plan.
parents right now. It's not.
But you see what I'm saying? Like, there's an opportunity there.
Yeah.
There's an
100%.
opportunity there to do better, spend less because the hospital is very expensive.
But it's a short-term opportunity. That's why I
Yeah.
would say it works in adults, but it's a short-term opportunity, because once you get to where you should be with your spend, right?
Then
Once you get to, then there's no more shared savings. There's
yes,
no more savings. You're right where you should be. And so it's a short-term solution in the adult market. It doesn't
yeah,
work long-term. And in pediatrics, it doesn't work at all,
it doesn't
because
work.
most of the money we spend is on the thing we're supposed to be spending it on, which is prevention, which is what we should be trying to get to, because then that's going to save money on the back end in the adult population. So we're valuing the wrong thing. We're valuing the savings. We're measuring the savings, the short-term savings, instead of the long-term benefit to the population and the healthcare system and the health of our country as a whole. That's the problem. What we need in a value-based system is to reward things that are going to get us to a more efficient, less expensive, healthier population. And instead, we're valuing it, or we're measuring it by how much we saved in a year. That doesn't make any sense.
Yeah, I think the reason they do that is the insurance carriers say, why should I invest in this child
Correct.
20 years?
100%.
And then they're healthy, and then they move on to another company, and they don't get diabetes, they don't get obesity and things like that. And those
It's the wrong pocket.
That is a narrative that destroys our ability to negotiate. And Dr. McQueen was very clear with you on the podcast about that. That is not true. So when an insurance company says, oh, why should I, which they don't, but they say, why should I spend $1,000 on Johnny? And then he moves on and I don't get the savings when he gets sick 10 years down the road.
Yep.
Because Mr. Insurance Company, when Johnny's sick 10 years down the road, he might have gone from Anthem to United to Aetna back to Anthem.
Mhm.
And you're going to get those savings. And if you're not talking that language, we're saying, oh, they only care about the quarter. They'll play along with you to give you less reimbursement because you just put the hook on yourself. Okay.
Yeah,
So,
the real reason is because their goal is to get the money now. They don't
yeah,
care
that's
about the
all.
money later.
And then we
That's
talked
the issue.
and then we also need to talk about this because we talked about this before. The way you loop around that is by talking to the Fortune 500 and the biggest employers in your region about how they're on the hook for this money no matter who's paying the claims. That the school system in Lincoln, Nebraska is on the hook for that child until he's 25 years of age, as long as the teacher's still working for the system. And you can pay now, you can pay later, but you're going to pay anyhow.
That's why the best model in my mind, if you're going to do employer-based insurance, is direct to employer, right? Because what I do is not a risk, right? It's not like getting your fire insurance, right? And your house might burn down. And so there's going to be a few catastrophic cases, but most people are just going to pay and support the people with the catastrophic cases. And then there'll be a little bit off the top for the business to make, right? What I do is pretty predictable with a few catastrophic cases. And what really makes the most sense from a preventative standpoint and from a pediatric standpoint is direct to employer for the outpatient piece of it, right? You pay me to do all the preventative care for your patients. You pay me to do all the chronic care management, chronic disease management. We'll provide behavioral health services. We'll provide asthma services. We'll write prescriptions. We'll do a good job. We'll do their vaccines. And then you can buy a catastrophic plan to cover everything else.
All right.
That
So
model makes so much more sense.
Hold that thought, because I love that. And you're so much closer to where I want us to be. But hold that thought, because I got a couple of questions in between. Okay. So your practice is phenomenally well run, creates incredible value for your patients and your staff, has a tremendous impact on your community. But only 10% of your payments come through value-based medicine.
Oh, 100%. Yeah, you're right. And that's only in the last 3-4 years. We are on the back end of that movement.
And in a big part of it, there is a ethical consideration about these payments. Okay. I don't think anybody could disagree that screening for depression at the 12-year-old visit is not necessary, but still doesn't get done. But we do get into trouble when we start talking about what they measure as far as vaccination rates. And I've been very vocal. I think if you don't want to vaccinate, don't bring your kid to me. I don't want I don't want to worry about it. Okay. But there's a flip side, which is, what if you really are an Orthodox Jew and you live in an Orthodox neighborhood in the Bronx, and 80% of that community doesn't vaccinate the kids until before they go to school? So you're just going to send all those kids in the emergency room because you're going to be, I couldn't practice like that, but I'm just saying there are good people who have poor quality measures because they're not reaching the target vaccination rate for their state. But they're in a community that does not accept that.
Yeah.
And they're trying to do the best they can, and they're being penalized. So what is the solution? Deny all those kids care? Just send them
So
to the ER?
that's a social determinant of health, right? So that's the other piece that is missing in value-based care is, how do you measure social determinants of health and take those into account so that you can modify your expectations of a provider and their success? Because the population you serve and all of the external factors that affect that patient's healthcare, whether it's a religious issue, whether it's access to transportation, whether it's whatever that social
Mental
determinant of
illness,
health is.
mental illness, drug addiction.
Employability, financial insecurity, all of those things affect the success of the physician. No matter what we do as a practice, there's going to be a limit to what we're able to overcome, even if we put a lot of resources into it. And it costs more to do that, right? So that's why this is so hard, because the value is not simply shared savings, period, or hit this quality measure, or this is going to average out of. That was when we were in a medical home program prior to our value-based or our ACO contract, they were telling us that our percent of prescriptions for branded pharmaceuticals was too high. And so we weren't going to get our award. And we were doing all of our own asthma care, and we were actually diagnosing kids and controlling their asthma. And so our asthma rates were through the roof as far as quality, and we were saving a ton of money, and kids were not going to the emergency room. Kids were not going on inhaled steroids. We have a lot of asthma in Nebraska, a lot of allergies. And the people who were not treating the asthma looked like all they ever prescribed was amoxicillin, right? But we were prescribing every single month Flovent. So we're doing a better job of managing the patients, but we weren't hitting. And the pharmacy executive said that would average out. The reality is you have enough patients that you shouldn't be any different than the average pediatrician, and they don't get it. So that is a problem with having metrics that you meet. But you have to look at, there's got to be a way to do it, okay? Because the actuaries,
so
all kinds of crazy stuff.
so we'll get there.
The actuaries work for the insurance company.
So not necessarily, but we'll get there.
We have actuaries with our ACO, and that's one of the reasons why we're so successful. But a tiny little practice on their own is not going to have the ability to do that.
No, but I'm going to use examples to go through how not the actuaries, but the healthcare economists look at
Yeah.
this. And Dr. McQueen just it just blew me away. He said, some of the questions that you're asking are not economic questions.
Yeah.
They're ethical questions. And so I'm going to give you an example of an ethical question. Should every child born in the US have access to vaccines? That's an ethical question.
Absolutely.
It's not an economic question, it's an ethical question. Should every child in the US have access to free K through 12 education? That's an ethical question. You could argue and shoot yourself in the foot that's not necessary. It will destroy the democracy. But that's my opinion and my ethics. I think they should. Okay.
But the economic question is, what is the economic impact of every child being vaccinated?
And what is the economic impact of children being
Right.
littered?
Right.
Okay. Yes. But he said some of these questions that you're asking her are ethical questions.
Mm-hmm.
The first thing society has to decide for itself
Mhm.
what it wants to look like, and then figure out how it gets paid.
Mhm.
So when we talk about value, which is cost savings for the purpose of this example, the polio vaccine has no value because we don't see
But that's
polio.
not how I define value.
Right. It has no value because we have zero spent, thank God, on paralytic cases of polio in the US because everybody gets vaccinated. And the last time we really saw deaths from polio were in the 1950s before the vaccine became widely available. And anybody that denies that, says it doesn't work, is Looney Tunes.
Mm-hmm.
Okay. However, you cannot put a monetary value to the peace of mind that mothers across America have every summer when they send their kids to the pool and they know they're not going to come back paralyzed.
Mm-hmm. Yeah.
There's
But there
no
is
amount of money.
I would disagree though about the economics of it, right? Because what you'd have to do is you'd have to project out what's the value, just like they do when they make a vaccine recommendation. When the ACIP goes through and the CDC goes through with vaccine recommendations, they look at what the impact is of vaccinating a certain percent of the population, the cost of the vaccine, and then the long-term cost if you don't. And they look at that, they project it out, and they look at the economic impact. So there's still an economic
I
impact.
don't think they do, Sean, because
Yes, they do. Did you look?
I asked
I watched it.
I asked Paul off at that. I said, if you spend $100 boosting every child with COVID, every 350 million of us for COVID every year.
No, they haven't done that. But when they first do the vaccine approval, right? So you could do that with polio vaccine. You could say, if we stop vaccinating for polio, where are we 20 years from now? The problem is we're only looking at the short-term value. We're not looking and the short-term impact, economic impact, and not the
So
long-term.
Dr. McQueen said, that's not true, Herb, again. He said, every healthcare economist has two measurements,
Mhm,
years of life and quality years of life.
mhm.
And whenever you do an intervention
whether it's a pharmaceutical intervention like
Mhm.
this new drug for sickle cell disease or
Yeah, then
hemophilia,
you look at the economic impact
and
based on that. Correct,
you
yes.
look at the quality of years and the longevity of that life
Mhm.
and the lesser cost that they spent.
Right.
So we could model out what the economic impact of failure to polio
But
vaccine.
the value-based programs aren't looking at economic
No, they're
impact.
not.
They're
But
not.
the
That's the
impact,
medical economics,
that's a matter, but
economists.
the impact, you cannot put a number to the peace of mind of sending your kid, your grandchild to the pool in the summer knowing they won't come back with paralytic.
Sure, 100%.
There's just
But
the impact.
but I don't think that is talking about the issues with value-based care. The big issue is you're talking about a medical economist versus a business strategist, and that those are not the same things. So the insurance company executives that are offering you a value-based plan are looking at short-term economic impact. The economists might be looking at short-term and long-term, but the business executives are looking at their fiscal year. This is the year that I care about right now because I answer to the shareholders. And to a certain extent, the pediatricians are too, right? Like I care about this fiscal year because if I don't get paid enough, I'm going to close my doors because I can't pay my staff. I can't pay myself. I can't pay my bills. So we're all looking in this narrow little column and we need to be looking at the big picture and then valuing things. But I still don't believe that value-based care has to be shared savings based. I think
No,
that,
that's absolutely right. And
that,
we're gonna move
yeah,
into that what you're talking about the model because I love your model. Uh,
Maybe they should just change the name to something else.
they do. Most people now are using alternative payment models, right? Which is a new fancy name for value-based.
This episode is sponsored by our friends over at Freed AI Medical Scribes. Let's hear what they have to say. What if you could take the computer out of the physician-patient relationship? With Freed, you can. Freed is the AI medical scribe that listens, transcribes, and crafts perfect silk notes for you seamlessly. This isn't just another productivity tool. Freed is a life-altering solution for physicians, helping you regain the joy of practicing medicine. Freed frees you from the burden of documentation, so you can focus on what really matters, your patients. With Freed, the computer is no longer a barrier. It's a quiet assistant that works in the background, capturing every word of your patient interactions, accurately and quickly. The result, you're fully present in each visit, building stronger connections and offering more attentive care. And when the day is done, your notes are too, leaving you with more time to focus on yourself, your family, and your life outside of medicine. Freed is the solution thousands of physicians swear by to reclaim their passion for medicine. Obesity is another, what should we call it, disease process?
Mm-hmm.
I think it's a disease. And if you try to do obesity in your clinics,
Mm-hmm.
it's hard to make money at it because
100%. Yep.
it's very labor intensive.
Uh-huh.
And
And it
then
drives up our cost, right?
it drives up your cost.
Big time.
And there's no short-term benefit to it. And so you're actually penalized for doing the right thing, but we all
Mhm.
know we don't have the studies. This drives me nuts. There's no Farmington studies that say if you're obese when you're 10, by the time you're 45 years old, this is your cardiovascular risk. That
Right.
doesn't exist. Um, but I think intuitively we all understand that if you're obese at a very young age, you're going to have more knee replacements, hip replacements, strokes, heart attacks, type 2 diabetes, all very expensive and horrible disease processes that will really impact your quality of life. And if you start at 10, it may be starting at 40 when you're still a fairly young person. But there's no way of showing that so that we can get more money to do that work.
Mhm.
Another
But there
one,
should be.
there
And
should
and
be,
and
there
there
should
should
be,
be, and
there
it's
should,
totally possible, and especially with the stuff that they're doing with AI now, it's not gonna be far. That's what that modeling is, right? That's
yeah.
where you have to take the data that you have, put it into a model, and figure out what are the cost savings. Okay, this is a and then you're right, then you have to ask, okay, there's no cost savings. So from an economic standpoint, it doesn't make sense, but then there's the ethical point, but we should do it anyway.
That's right.
Those are two separate questions, but that doesn't mean that it doesn't have to fit into our value set and that we value it as just like you value. You might not value sitting in first class, and George does because he is independently wealthy and he can
He
sit in
is
first
very
class.
wealthy. He's very wealthy. He always travels first class. Just so he can irritate me. And then another one, for example, screening for type 1 diabetes or breast cancer.
Right.
Again, there's a cost to doing the screening. And then if you discover it early,
Mhm.
which has tremendous impact on that human being, you spend a whole lot of money.
Yeah, 100%.
And so then you look bad because you're spending a lot of money. And then we go back to what we said over and over again, shared value, shared cost share, shared cost and
Mhm.
share
Mhm.
savings
Yeah,
is
shared
not a
savings doesn't work.
model.
It
It's not
doesn't
a
work.
model that works, particularly in preventive medicine or
Yeah.
pediatrics or young people.
Mhm.
So here's where it really gets interesting. Let's start with the ethical question of should every child born in the US have access to preventive care like they do through education K through 12? That includes vaccinations and screening.
Mhm.
And it should be provided by at least office that is led by a pediatrician or family practitioner. They
Yeah,
also do a
family
lot of things.
practitioner. In our state, it would have to be family practice. We just don't have enough.
And in some areas, it's going to be a family nurse practitioner because that's a count.
100%.
But as long as the protocols are set in place by someone with a lot of experience in the care of children and there's back and forth communication,
Mhm.
then it's what children deserve.
Mhm.
To me, that is the ethics. Yes, that should be provided. That has nothing to do with Medicaid. That has nothing to do with insurance. That has nothing to do with nothing. That's not an insurable risk because it's not a risk.
It's not a risk, it's a service.
It's an investment.
Yeah,
An
it's a
investment.
service and it's an investment. It's no different than K through 12 education.
It is no different.
Mhm.
So we can now move on to how do we
Mhm.
finance? Do we finance it like we do through K through 12, which drives people nuts because if you live in a wealthy neighborhood, your schools are better because you pay more taxes? I can't help you there because the Constitution says the power is not enumerated to the federal government or that's of the state. And that's why we're locked into that. We could amend the Constitution and fund K through 12 at the same amount in every jurisdiction in the country, but it'll take a constitutional amendment. Ethically, we should provide it. The next questions that we should be asking is who finances it and how do we pay for it? But that should be for every child born in the US. And in my idea is very simple. Child support or your food stamps. It is a debit card. You show up to George's office to get your 2-month-old well child exam. He rings it, he gets $300 for the visit. If he doesn't do the visit, he loses the money.
Mhm.
There's no friction. We don't need a United Healthcare. We don't need networks. You got a license to practice medicine in your state. That card works at those physicians that are licensed to do that. You ring it, you get that done. We're done.
So now I'm gonna throw a wrench in your theory here. You
Okay.
are coming from the perspective, okay, that every pediatrician and every family practitioner and every family nurse practitioner and whoever is providing the service is going to provide the same level and the same quality of service because they are ethical. And that is where we've gotten into trouble with this whole value-based care thing is the argument on the other side is we don't want to just pay people to churn out more procedures or churn out more interventions and have them not be good quality. And you and I have a hard time with that because we would never not do that because that's our ethical basis. But we know that there are people who don't.
Yeah.
There are people.
Most pediatricians do the right thing.
I think most pediatricians do the right thing, but there are some physicians and nurse practitioners, and whether they're pediatric or not, that see 30 well child checks a day, 40 well child checks a day, and they're not providing. I know
That
that
is happening. It
it
is
is happening.
happening.
Yeah.
And it happens in pediatrics, obstetrics,
Yeah,
everywhere.
it happens in all
So,
kinds of
so,
areas. And
so when you
you
talk to
do have to
women,
have that value piece. You have to have
yes,
that quality metric value piece. And I think if you have that, you can help to control that. I think that's a fair, that's no different in my mind than direct to employer. It's just instead of it being the employer base, which I think has all kinds of problems, But
Yeah.
that's also a result of unintended consequences from economic controls in the past. But our employer-based system really should push us into direct to employer. And then we have some other system to take care of kids who don't have that access to that.
And so I think if you do the math, somewhere between $40 to $60 per member per month would cover what we're already doing, including vaccinations. So for what it is, what the routine, right? The cold, the asthma, things that don't need hospital care, you could go to a membership model,
Yeah.
Netflix. We can decide if you're on Medicaid, the state pays $40. You, as a physician, you can provide, you can say, I can do it for that amount, or I can't do it for that amount. I don't know, your local school system might say, I pay $50. And you might say, I can't do it for that amount. I'll take the 50, but you got to pay me $20 extra a month because I'm not doing it. I can't make it work. And then the consumer will judge things like, are they open after hours? Can I talk to someone on Sunday? Do they send me to a specialist that costs me more money every time the kid wheezes? Do they just tell me to go to the ER when the kid has a fever? That's not really valuable for me because I'm already paying for that service. So they will switch to someone else who gives them the service they need. Um, right? And then
Sure.
it'll have to be financed differently. Maybe the school system in Lincoln decides it's going to provide that for all their school teachers because it's good for them and their productivity. For people that are truly indigent, then maybe it's a state and federal partnership that pays that some. For others,
Beautiful plan, Herb. How are you going to make it happen? And you still have to account for there's still going to be variations because look,
in
there are
care, yeah,
pediatricians there who have a special interest in caring for kids with asthma, say. So
yes,
they need longer visit. There are pediatricians who do more behavioral health care. There are
yeah,
pediatricians who do more autism. There are pediatricians who do more special needs. And so there's still going to be variations, right?
there
And
is.
you
And
still
Those
have to,
mental ingredients you're talking about are time sucks
yeah,
and financial demands.
right. And
But it
what
One
can
not
be
happens,
done. It can be done if the system's set up to do it
it has to.
properly.
yeah, it
And
can
you're
be done.
absolutely right. That
But we have to model it and
the
figure out how
third
much it
rail, the
costs.
third rail is the catastrophic care, which is really what insurance is for.
But asthma's not catastrophic care.
No, but if you get leukemia, it's catastrophic
Yeah,
care.
right. If you end up
And
in the NICU, it's catastrophic
the
care, right?
catastrophic care, right? And it should be capped, at least in Virginia, there's caps on malpractice. But it should be capped to $500,000 a year, 2 years through a lifetime. And then whatever the other insurance product does is if you fall out of that, what they're insuring you or that risk, they buy reinsurance and you end up in a reinsurance pool my cousin does reinsurance for a big company in Europe. And he explained to me, is you buy your car insurance for State Farm. They have modeled out with the actuary tables that in any given day, 5 cars are going to be totaled. They make reserves to pay that claim out. But they have no idea that one day in Virginia, where there's never been a major earthquake, there's a freak of nature and there's an earthquake and they lose 5,000 insured cars that are totaled.
Yeah, they have reinsurance.
They
Yeah,
have reinsurance because they don't have the money to pay that out. He said,
yeah,
like the Twin Towers, it wasn't the insurance companies that, not like whatever State Farm or whatever
right.
buil-
Right.
I don't know who insures buildings that size, but it was Swiss Re
Right.
who reinsured for an unforeseeable event, ended up paying for their reconstruction. And then again, we have to then say some parents can afford to pay for that. Some people are going to need government help to pay for that. And some people might get that through their employer. But that's where we need to move
But
in order
that's not
to take care
so
of
the lobbyists that are pushing all this stuff right now, they don't work from that standpoint, right? They work from I work for the hospital. I work for the insurance company. I work for the big healthcare system. And so they are really focused on the fiscal year. What is going to keep us successful? And if they're for profit, profitable, and if they're not for profit, whatever you want to call that, what is going to keep us going till next year? That's what they are looking at. And you are looking at the big picture. And that's the problem. And that's what the medical economists are looking at, right? They're looking at the big picture because they're looking at lifetime. But the people who are making the decisions and the people who are writing these plans are not looking at the big picture.
But do you think if we start talking about the big picture,
Mhm.
we may not see a change today, tomorrow,
100%. Yeah.
but maybe. So right now, we talk about Medicaid for all children, which would be a disaster in many ways. But the biggest disaster, the two biggest disasters in the idea of Medicaid as an insurance plan for children is that it competes with people who are aged and really infirmed and
Mhm.
disabled that really need the resources. And the
Mhm.
kids don't need that many resources.
Yeah.
So
Look
now
at the rhetoric that's out there right now, right? They're talking about Medicaid as a program for poor people. And
yes,
Medicaid is a program for poor adults and almost 50% of children. But
yes.
let's change the narrative a little
So
bit,
it's a problem.
because
So the
yeah,
child doesn't belong competing with the aged and the disabled who has big spans and needs to be a caring society. So that's a problem. Two,
because it's a health insurance plan.
it is
It's
not a
not.
health insurance plan.
No, but you
No,
see what I'm
don't.
saying? They're looking at it from an insurance standpoint, paying
Yes,
for catastrophic stuff as opposed to investing in
yes.
the health, right?
Yeah. The Medicaid was not built to invest. It was meant as a safety net when everything else failed and the payer of the last resort. Okay. And the other thing is Medicaid, as it should be, because we live in a democracy, is vulnerable to the whims of the elected politicians. We live in a democracy. It isn't perfect, but it's better than any other system. So some politician might think that we should spend nothing on defense and all on Medicaid and Medicare because it serves our communities. Nothing wrong with that, except we get invaded. Then other politicians will say, no, that's just a wasted program. Why are we wasting money on that? The biggest threat is China. Let's spend the money on defense. They're not evil per se. They just have a different perspective,
They have a
but
different set of values.
different set of values, and they have a yearly appropriations, and they gotta make that budget fit.
Mhm.
So
Yeah,
when
they're
we,
also focused on the fiscal year.
yes, they are, and the next election cycle, which is
Right.
every 3 years
Right.
for the House. So, so if you lump the kids into a program that is not about investing in the future, that works like a payer of last resort,
Mhm.
that is vulnerable to the whims of the last elected individuals,
Mhm.
and it is short-sighted in the term of years or months, we're never going to improve.
Yeah.
So they don't value putting any monies into the budget for children with these
No,
value-based
because they don't vote.
because they're both
Well,
correct.
it's because they're lumped into that big Medicaid, and then we're spending $5,000-6,000 a month that's being paid by the federal government, enabled young adults that got in through the ACA, but we're spending $2,000 on the kid that's poor and needs the interventions. And
Yeah.
so people go like, how can that's not right? That's not right. Why are we funding that at that level? But they don't see the intricacies of it. They just see Medicaid as evil because of this one thing, or Medicaid is glorious because it gives every kid something.
Yeah, that means so my perspective as a pediatrician is Medicaid allows the patients I care about to get what they need. So to me, it has great value.
Yes.
I'm
So,
only
so
seeing one piece of it.
yeah. But so what I'm urging is that we move to educate and tell people investing in kids is not compatible with insurance products or payers of last
Yeah,
resort.
I'm with you. And I think we
And we
can come
need
up
to
with
move
a
forward.
value-based system that pays for the services that are controllable and predictable and encourages it to be produced in a way that makes sense, that is high quality, and also predict how much those costs are going to be more accurately so that it fits different pieces. With the technology and AI, there's no reason we shouldn't be able to do that. The hard part is going to be capturing all the social determinants of health that fold into that, because so
I have
many
a
of them
quick
are.
idea. What if the three of us were challenged to design a good care program, value-based, whatever you want
Oh,
to
I
call
would love it.
it, start? How would you do that?
We just talked about how we do
Yeah,
it.
Rob
We
just
would,
told you.
we
I mean,
would break it up into three needs that people
yeah,
have, which
yeah.
is investment in prevention in the future of a democracy, which
Okay.
is
Yeah, but
education.
you're talking big, your global scheme.
Well, that's where you
One
start.
thing is, you hear all the time, our healthcare system's too expensive. We're spending too much money on our healthcare system,
Yeah,
right?
but it's not you that's spending it.
100%. But Herb is right. We're spending it on different pockets of care, right? Some of it is preventive, and we're not doing enough of that. Okay.
Okay.
Some of it is not catastrophic, but really expensive care. And some of it is really bad, catastrophic, right? So we've got these three pockets of care that we're paying for. If we start putting more money into this preventative, we're not going to see it decrease our spend
Right.
for another 20 to 50 years, 10 to 50 years. Okay.
Okay.
So you have to accept that it's going to cost more at first, because you're still going to be spending on these two pockets over here and investing more here. You cannot take from these catastrophic and high cost things to spend more on prevention without removing the care that these people who are already sick need. So
Yeah.
you have to increase your spend in an effort to, over the long term, decrease the spend in these groups. But you also have to accept the fact that you might not completely decrease this, because people are going to live longer. People are going to develop new diagnoses that they wouldn't have had, cancers and those kinds of things. But there's got to be a way to model that out. But nobody's willing to accept the fact that you're going to have to spend more to spend
No.
less later,
And I would argue
because they're
even,
looking at the 1 year.
and I would argue even further, and by no means a liberal or a socialist,
Uh-huh.
but I would argue, what is wrong with a wealthy society spending 20% of their GDP in
Yeah.
health?
Yeah.
What is wrong with that?
Yeah.
Because you know what? In the world we live today is a very globalized world.
Uh-huh.
There are many other countries that can produce cars, refrigerators, televisions at a much cheaper rate than we can manufacture them. But a doctor sitting in Colombia, where I'm from, or in China, cannot look in the ear of your kid and put his arm around you and tell you it's okay. And the healthcare industry provides good middle class jobs for a lot of our communities. And that is a tremendous impact in your community, not only because you're healthier, but these people are, you have 150 families that get fed because you see kids in the office and they take that salary, whatever it is, 30, 50, 60, $70,000, and they multiply it times 7, because then they go out and eat dinner with their kids, they buy shoes for their kids, they buy cars, they pay rent, they buy homes. And so maybe it's nothing wrong. We should be okay with spending 20%
Oh,
of
well, maybe we
GDP.
shouldn't be measuring it also as all one thing.
No, you're absolutely right. But I'm just saying, when people say we're spending 15 or 70% of GDP in healthcare, I'm saying if you're a very wealthy, very advanced society, maybe that is where the spend should
Uh-huh. It could be, but I
be.
think people would argue that our population and our outcomes are
That's
worse
the
and our
problem.
spend is more. And I would tell you it's because we are looking at it as one big bucket of money, and we're only spending less than 5%. I think it's 4.7% on primary care
So
of
does
that big
50,
bucket of
so
money.
does 50% of the visits.
Right. So we're spending a tiny amount over here. How about we look at that as a percent of GDP, and then this interventionist type of care as a percent of GDP, and separate it out? and then look at the value.
Yes. And then there's a phenomenal program that I'm just fascinated. It was in Leah Gagino's podcast. It's called RX Kids. And they're doing it through MSU in Flint, Michigan, and now they're going to expand it to Kalamazoo. And the basic premise is simple. All these social determinants of health can't be factored into a payment formula or quality.
It's so hard. And you can't capture them all.
So what they do is a not-for-profit. Every mom that lives in Flint, when she becomes pregnant, she gets a $1,500 gift for whatever need she has during the pregnancy. And for the first 12 months of the baby, she gets a $500 gift. There's no income restrictions. You can make $300,000. You can make $20,000. You still get it if you want it. You can spend it on whatever you want. And they've seen that the rates of immunizations, the rate of maternal depression, the rate of well-child completed visits, all improve.
Crazy idea. They had this a couple of years ago, about 10 years ago, one of the managed care Medicaid plans. They would give gift cards to Toys R Us for your child if you went to see the doctor, if your vaccines, if you, all these quality metrics. If you had 4 kids, you'd end up with a good couple of $100. And you know what? People came in.
Yeah, they did.
Dangled the Toys R Us gift cards. Hey, come to the doctor, then go shopping at Toys R Us. Really? Do we have to do that? And sometimes the gift cards added up more than what the doctor's charges were.
Of course, they always added more. But what I'm saying is, these are the social determinants of health. And again, it's an ethical question.
It's a bribe.
No, it's an ethical question. Do we need to support women having children because it's necessary for the survival of our society? And we do. And we do. Do we need women to be healthy? We do. And do we need children to be healthy? We do. And so health insurance is not a good model to incentivize that or support that. So we need to start looking at out-of-the-box solutions that lift pregnant moms and young children out of poverty and provide them with a leg up so that they have a healthy future. Because it's all selfish. They're going to pay for my Medicare and my care as I age. And without a strong economy, this whole democracy thing that we have, which is great, collapses. And I'm too old. I can't start all over again. Okay. So I need these young kids to be
You're
strong.
talking to me. My husband is online in the evening looking at homes in the UK to move to, which is where I came from.
I'm moving back to Colombia, and it mortifies my dad. He goes, why? I said, because in some cultures, the age, I can't say old, are treated with respect and kindness.
Yes.
So I'd rather live in a little apartment where I can afford a maid and a driver and than in a nursing home.
Oh, brother.
Right? It's true.
But ultimately, we are in a society right now that doesn't even have parity with Medicare for our children, right? So we're not valuing our children. We don't even pay attention to it. It's a small, they don't vote, they don't have any kind of influence. And so we're not, and those of us that are advocating for them, we don't have a lot of influence because there's not a lot of us either. We don't have a lot of power. And so we can do our best to try to raise the voices. But until the society and the community values children, ultimately all of this is sort of, unless we separate it out as a separate program. This is not a healthcare program. This is a preventive medicine program. This is your sick care program. This is your well care program.
But I think if you talk to anybody, I don't care how far right libertarian, that we should do away with K through 12 education, they tell you you're absolutely nuts. And they would stop talking to you.
Should talk to some people here. There are people here who think really they don't want to get rid of K through 12 education, but they really don't necessarily think we need to be doing all the things we're doing in K through 12 education, and it should cost a lot.
Okay.
The best
And I
years,
think if you ask most people, is it ethical not to
No,
invest?
I agree. I agree completely. But I think
The
most people,
conversation changes. They're like, most people, like say 90%, 80% of people say it's not ethical not to invest in the future. People feel that the baby might not vote, but the mama votes and the
Mhm,
grandparents vote. And if
mhm.
you make it you really want your grandchild to grow up sick?
Yeah.
which the
But when
business,
they go to actually vote, they don't always vote based on their ethics.
yeah, the people
Yeah.
that are running the business,
Oftentimes they vote based on their concern about self, their
Yeah. Or,
self-interest. So
or their one
their
issue,
emotion and their self-interest.
their
Exactly.
one issue, you know?
Yeah. And so even though theoretically they might say one thing, when they go to the ballot box and they go to vote on whether or not to increase their taxes to pay for a new school building, they vote against it, even though they do feel like K through 12 education is important.
Yes.
Yeah. And that unfortunately is the reality. That's why we have no parity with Medicaid in most states across the country.
in the healthcare industry, it's run by MBAs, administrators, all these non-doctor people, because doctor, you go in the room and do what you do best. We don't care about your opinion. Who has some ethics?
Right.
Business people, they don't have ethics. They do money. It's as simple as that. I don't know if you were, I mean, you were around, Sean, when President Obama was in charge, they made parity for Medicaid lines of
Yeah.
businesses.
Yeah.
Everybody was at 100% parity.
Yeah. Right.
That's great.
Yeah.
What's wrong with that?
Yeah. There's nothing wrong with it,
That
you
shouldn't
know?
be the
Okay,
war.
here's what was wrong with that.
And the second that it wasn't required anymore, a
It went
lot
away.
of states dropped it, went away, right?
Yep.
Because even though they thought it was ethical and they thought it was a good idea, they still had to make their budgets balance. Okay.
Yep.
And they didn't have the money and they didn't want to raise taxes. And so it went away.
What they did was they wanted to give you money to be able to get computers in your office through meaningful use. In order to do that, you had to get more Medicaid patients. Everybody got more Medicaid patients. They were in the office. You increase the parity with Medicare. Life is good. You got your computers, you got your patients, everybody's in, and then boom.
You're triggering me. That's a classical socialist play.
What that is.
To promise something and give something to people and not have a long-term funding solution for it.
Or
And
you
then
give, and then
It's not
when
just socialist. That's what you're saying. And it is.
when
sometimes
everybody's
right?
in the boat, you go, you're on your own now. And
Any
so the
different than
problem
what we
there,
were talking about with the
problem there
contract
is that
negotiations.
there was no long-term funding solution. That
Same
was all
thing.
paid
That's
by the
what shared
Fed.
savings is. It's not a long-term funding solution.
No, but you have
It's not
to,
just socialists. It's everybody. Everybody
but
has
when
a
I
big
talk
plan.
about these plans, I like to hit everybody. I like to make everybody upset at me, not just one person. If you're going to make one person upset, why not make everybody upset? Okay. But for this ethical funding of preventive care for children and young adults, it should come from an excise tax of health system revenue, insurance companies' revenue, and not-for-profit institutions who are not paying taxes. 1%, 2% is nothing to them. And it goes like the Federal Deposit Insurance Commission. The banks have to pay an excise tax, a percentage of their assets as into this program that the appropriators in the Hill can't touch. So the funding's always there. You don't raise anybody's taxes, and it's equitable because you know
But
what?
when here's the kicker, okay? You got
United Healthcare will never give up its 1%.
well, yeah. So one, they've got all the lobbyists, right? But
Yes.
so you've got the three buckets, right? The really catastrophic, the interventionist but not catastrophic, and then the preventive piece, right? And the goal is you spend more money here and you save money over here eventually over time, but it takes some time, right? So the problem is if this bucket shrinks and it's being taxed, then you have less to spend here. So
Yes.
that doesn't necessarily fix the problem.
No, and you're absolutely right. I had not thought about that. And part of the reason healthcare doesn't change is the same mechanics as a coal mining industry. We want to put hospitals out of business. Not because they're mean or they're necessary, but if people are healthy, they don't need these really expensive interventions. But when we put the coal miners out of business, how do they make a living? And so the hospitals are going to try to prevent any of these changes because they don't have another way of making a living.
Are they
Well,
not?
interventions is how they make most of their money, right?
Yes.
Because of, in fairness to the hospitals, right? They've got EMTALA rules and everything else. So they've got to fund all this free emergency care that they're doing that's very high cost. And the way they fund it is by doing procedures in the operating rooms and doing downstream revenue of interventional radiology. And that's how they fund it.
And
So,
we're no different, right? You get what, not everybody, but some people get paid for doing that depression screen,
mhm,
even if it's just $5.
sure.
But you're like, okay, I'm going to get paid $5 for doing that. Why wouldn't I be doing it? It's a good thing to do.
Huh?
I'm going to do it on every kid, right? So you do it. They're like, people are going to die if they don't get their cancer therapy.
Huh?
Why wouldn't I do it? And I make money at it.
Huh?
People feel so great after they do their knee replacement, and we make tons of money at it. And the customer's happy. Why wouldn't we chase that revenue line?
Right, 100%.
They're not evil. They're not
no,
evil.
no,
They're
they're
just doing
doing
their job, and they're
right,
maximizing their margins at doing their job and trying to do quality while they do their job.
which
Uh,
is why you have to have quality and value as a part of how you motivate people.
okay.
Because if you financially motivate people who have to run their businesses, we live in a capitalistic society. If you financially motivate people to do the things that are ethical, that are good quality, that are good for patients, it's a win. But you
Mm.
have to have that piece in there. It can't be fee for service alone. You
No,
read
no,
most,
no. I agree
yeah,
with you.
yeah,
I agree
yeah.
with you. What you were saying, what pops into my mind when you say that. So when you say I'm going to align the financial incentives for pediatricians to do what's best for the kids.
Mhm.
What impact do you think that would have on the burnout and the longevity of our professionals?
Oh my God, it would help so much, right? Because now you're getting rewarded for doing what you already want to do and you already know is best, right? And that is the biggest frustration. That's one of the reasons why we have a physician shortage, because we have people retiring early. My plan is 5 more years. And that's crazy, right? I'll be 56, but we'll see if I get to do it or not. But I think the reality is people don't want to do this job for their whole lives like they used to because of moral injury and burnout. And I know some people don't like the term burnout, but you all know what I mean. You don't feel
Yeah.
valued. You don't feel like what you're doing, other people think is important, and you've worked really hard at it. And you keep having people put barriers in front of you to make it more difficult. And that example of the carrot and the stick with the whole Medicaid thing, take more Medicaid patients because you've got parity. And then all of a sudden, poof, it goes back down to 40% of Medicare rates. And now you're stuck with it. What's the right thing to do to keep taking care of these kids? But everybody
And
else
we've
just wants
developed a
to do it.
relationship with them. And now you
Right.
gotta go like, oh, I'm just gonna drop you because I can't make money at seeing you.
And the
Sorry.
pediatricians are the worst at doing that. That's what attracted us to pediatrics in the first place, right? We're very soft when it comes to those things. Yeah. And I think that's why I think George is right. I think most pediatricians by far, most pediatricians are doing the right thing, but not all preventive healthcare is being done by pediatricians, right? So there's lots of other people out there. But I think that's,
And not all preventive care interventions
uh-huh,
are valuable.
100%. Yeah.
So then you have to decide what really has a value. And some things may not have a dollar amount to it as far as value, but have tremendous impact. So you're still going to do them. Thank you very much. We'll have to have you back and disagree on something else because we, at the
We
end of the day,
disagree. This is the
no,
crazy part.
no,
Every
we
time I
agree.
listen to you, I'm like, yep, we're saying the same thing.
We're saying the same thing. Yes. So
Yep.
we'll have to find something to disagree on because a conversation is only fun if you grow
Right.
from it. if you tell me how you feel, I tell
100%.
you how I feel, and then we try to edge closer to the middle and say, "Oh, we could do this or
Right.
that
Yeah.
together." That's what the fun of a conversation is. If
Totally
we
true.
if we
Totally
all
true.
agree on everything all the
I
time.
want to trigger her a little bit.
Oh,
Me?
no. I have an appointment to get to. I don't
But
want
you
to
gotta go. We're done. Time's up.
No, I'll let it go.
My vision of
Uh-huh.
what should be done is for all these children that had Medicaid, managed care in all states, they should all be reimbursed or paid to the physician at a minimum of 100% Medicare. Then you want to add these quality incentive programs for doing the right thing that are obtainable. That's your extra funding.
Yeah. I think that's
that,
totally fair.
at least that was fine. Herb would say 100 is not enough.
Yeah. And you know what? I think 100 should be the bottom.
Bottom, yes.
Should
And if
absolutely be the bottom.
you can give some extra money to pick up to commercial quality incentive programs. And I will assure you, a lot of practices don't even make that. I stumbled onto a meeting with one of the managed care Medicaid plans. They left a Zoom and they left their dashboard open, and I saw somebody else's profile. They had $1.5 million of potential earnings, accrued earnings, 30,000. You know what that means? They don't pay attention. They
Yeah.
just don't pay attention. And the 30,000 was done by accident.
Yeah.
And towards the end of the year. So that's where the extra money comes in. I don't, my opinion. You don't have to give an opinion, Herb. Because she has an appointment.
Yeah. But honestly, that's what you're saying is the minimum should be this amount that we're paying for the preventive piece,
Yeah.
right? Yeah. And then we're going to save money by motivating people to do
Yeah.
the things that prevents all of these expensive things over here.
Heck, but what do I know?
I think you know, George. Let's just
Not much.
almost as much as her.
But he flies first class.
Well, I only fly first class going to Europe, and that's on the way back regular.
All right. We have
All
to
right.
say
Thank you,
goodbye.
guys.
Thank you, Sean.
I appreciate it. Have a good rest of your
We
day.
love seeing you at the show.
Yeah. Okay. Bye, guys.
Please visit our sponsor. Incredible conversations like the one today can't happen without their support.